Today, the topic is going to be hepatitis B, and this is mainly on chronic hepatitis B, including the recent update from 2009 from the AASLD, which is the American Association for the Study of Liver Disease. And I'm Tran Phung. Hepatitis B virus, or HBV. So this is a electron micrograph of a Hep B particle. Below is the infectious particle called the Dane particle with the schematic of major structures such as the Hep B surface antigen, core antigen, and the Hep B DNA. A little bit of introduction. An estimated 350 million persons worldwide are chronically infected with hepatitis B virus. In the U.S., an estimated 1.25 million persons are hepatitis B carriers, which means they are positive for Hep B surface antigen for more than 6 months. 15 to 40% of carriers develop hepatitis B complications from chronic Hep B during their lifetime, and this is from from the practice guideline that was updated recently in late 2009. The recommendations from the guidelines pertains to the following, including the evaluation of patients with chronic hepatitis B infection, prevention of HBV, the management of chronically infected persons, and the treatment of chronic Hep B. The objectives, we'll go over the epidemiology, screening for HBV infection, serologic profiles, the natural progression of HBV infection. We also touch base on management of chronic Hep B, so who should be treated and who can wait, co-infections with HIV, and some key changes in the guidelines. I'll go over those. First up is transmission. So HBV is transmitted perinatally, percutaneously, by sexual exposure, or by close person-to-person contact, presumably through open sores or cuts. After the acute exposure, the risk of developing chronic Hep B infection is up to 90% in newborns of HBe antigen positive mothers, 25 to 30% in infants and children less than 5 years old, and less than 5% in adults. In the U.S., most infants, children, and adolescents have been vaccinated against HBV, so they have a low risk of transmission in daycare or school. And this is the point for counseling, so that children are not isolated or prevented from participating in sports or regular activities. This is a graph of the epidemiology of HBV from a New England Journal article in 2008. The brown areas are areas of high prevalence, more than 8% HBV infection, so that's in Asia, Africa, and also, you can't see it well here, but Alaska, Greenland, and then also in South America, including part of Brazil, Peru, and Colombia. This is a schematic of HBV replication from the same article that shows the Hep B DNA virus incorporated into the host nucleus, and it replicates via reverse transcriptase. The steps where the drugs available for hepatitis B treatment block are, you can see it in various steps. Specifically, it basically block priming and DNA synthesis. And I'll go over the medication more later in the talk. So who should be screened for HBV infection? The guidelines have changed slightly. So before it was just screening in areas of high prevalence. Now the guidelines also include screening for patients in or come from intermediate areas. So individuals born in areas of high or intermediate rates for HBV should be screened. So that's all countries in Asia, Africa, South Pacific Islands, Europe, the Mediterranean areas, including Malta and Spain, all of Eastern Europe except Hungary, Arctic area such as Alaska, Canada, and Greenland, South America, Brazil, Colombia, and Peru. In the Caribbean, places like Haiti, Dominican, Jamaica, and then in Central America, just Guatemala and Honduras. Other groups who should also be screened include household and sexual contacts of Hep B surface antigen positive persons. Patients with chronic elevation of ALT and AST should be screened, dialysis patients, as well as all pregnant women, IV drug users, and MSMs, persons with multiple sexual partners, or people with a history of sexually transmitted infections, inmates, HIV and HCV patients, and also the new point in the guideline also include immunosuppressed or patients undergoing immunosuppressive therapy. A point on isolated antibody to the core antigens. So patients who are tested positive for the hepatitis B core antibody alone, meaning they only have the positive core antibody, their surface antigen is negative, and their surface antibody is negative. So what does that mean? And there are four possibilities. We actually see the isolated anti-hepatitis B core positive at a high level in the HIV clinic on patients with co-infection, sometimes up to 40%. So the four possibilities of interpretation for this isolated core antibody positive. One is that it's a false positive test in low prevalence areas. The second option is that the anti-core antibody here is a marker of immunity. So patients have recovered from a prior Hep B infection, and their antibody to the surface antigen has decreased to undetectable levels. Now, these patients have a good amnestic response to the hepatitis B vaccine, so only after one dose of the vaccine they have a high titer. Another possibility is that the anti-core antibody indicates chronic HBV infection in these patients. So their surface antigen level has decreased to undetectable levels over time, but these patients have a detectable HBV DNA level in the liver more than in the serum. And then the last possibility is that the hepatitis B core antibody is the only marker of HBV infection during a window period of acute hepatitis B. In these patients, they are also positive for the hepatitis B core IgM. Prevention of transmission from persons with chronic hepatitis B. So sexual and household contacts of carriers who are negative for HBV viral markers need to receive the hepatitis B vaccine. Newborns of HBV infected mothers should receive HBIG or IVIG as well as hepatitis B vaccine at delivery, and they need to complete the series. And the test for vaccination response in person at risk should be done to confirm adequate titers. There are 8 hepatitis B genotypes labeled A through H, and all genotypes have occurred in the U.S. The prevalence for these genotypes are the A genotype is at 35%, the most common. B genotypes 22%, genotype C 31%, D is 10%, and E is just 2%. Actually, E through G is 2%. Genotype B, as opposed to genotype C, is slightly better in the sense that E antigen seroconversion occurs at an earlier age, and these patients have more sustained remission after hepatitis B E antigen conversion. Patients with genotype B also tend to have less active liver inflammation, slower rate of progression to cirrhosis, and a lower rate of hepatocellular carcinoma, and these are from studies from Asia. Uh, this is, I'll go over the serologic profiles of acute as well as chronic hepatitis B. And this is a graph of acute hepatitis B. So in a typical course of acute Hep B, the replication occurs as demonstrated by the Hep B DNA bar at the top. And soon after the occurrence of Hep B vDNA, the Hep B surface antigen and the E antigen develop, and these are the first viral markers detected in the serum. The Hep B surface antigen may be detected as early as 1 to 2 weeks or as late as 11 to 12 weeks after exposure. The persistence of the surface antigen and the persistence of the surface antigen indicates chronicity or chronic hepatitis B. Hep B E antigen correlates with high level of hepatitis B virus replication, and so that's the marker for infectivity. Within a few weeks after the appearance of the HBV DNA as well as the E antigen, levels of ALT and AST begin to rise, and patient may also develop jaundice. The E antigen is usually cleared early at the peak of clinical illness, whereas the hepatitis B surface antigen and the B DNA usually persist for the duration of illness and are cleared with the recovery. Antibodies to the hepatitis B virus proteins develop in different patterns during the acute episode. So, for example, antibody to the core antigen appears shortly after the onset of illness, and the initial antibody is the IgM core antibody, and the IgM declined as soon as the IgM declines, the total hepatitis B core antibody begin to rise, and that can last over the next several weeks. The antibody to the E antigen at the top of the chart. So you see the E antigen positive for a short period at first, and then the last two-thirds of the graph shows the anti-HBe antigen. So the development of antibody to the E antigen occurs shortly after the clearance of the E antigen, and once the E antibody develop, there is that indicates the beginning of recovery. Now, hepatitis B surface antibody can persist after recovery, and it is the antibody that is associated with immunity against hepatitis B. Now, between 10 to 15% of patients who recover from Hep B do not develop detectable antibody to the surface antigen, and they only have the core antibody alone as a marker of previous infection. So this is why the core antibody testing for the core antibody can be a reliable means of evaluating as to whether patients had a previous infection with hepatitis B, and the testing for the hepatitis B surface antibody is used to assess immunity or response to HBV vaccine. The serologic profiles for chronic hepatitis B is also similar in terms of patterns of viral markers, but the DNA, as you can see, the DNA as well as the E antigen, and further down, the total core antibody and the surface antigen titers remain high for several weeks, even months after the initial infection. And person with chronic hepatitis B infection eventually are at higher risk for developing hepatocellular carcinoma. This is just a table of HBV markers that I just talked about. So this is one table that you can use for review. Some terminologies that's used to understand HBV infection. So in terms of treatment, you'll hear about hepatitis B E antigen seroconversion. So that just means it's the loss of the E antigen with the appearance of the antibody to that antigen. So, and this allows the classification of which patient in which category in terms of treatment, as in E antigen positive or E antigen negative chronic hepatitis. So again, this is the table for review. This is a flow chart of the natural progression of HBV, and I'll talk more about the different phases, but essentially you can have patients who are at the top here develop hepatitis B via perinatal transmission, develop into the first phase, which is called the immune tolerant phase, and then most of those patients, 90 to 100%, will go into the hepatitis B E antigen positive immune active phase. Most of those will seroconvert, meaning they'll lose the E antigen and develop the E antibody, and those patients, 80 to 90% of them will progress into the inactive hepatitis B phase, where they are relatively healthy, and up to 1% of those will clear of their hepatitis B surface antigen and develop the antibody, and thus have recovered from acute hepatitis. Whereas about 10 to 20% on the right side, 10 to 20% of the E antigen positive patients will develop the antibody, but they still have chronic active hepatitis. So here's the natural history of HBV. You have the acute Hep B infection. The chronic phase, a chronic Hep B infection is is divided into 4 phases. And again, one is immune tolerance. The second phase is Hep B E antigen positive chronic hepatitis. The third is inactive Hep B surface antigen carrier, or inactive carrier state. And the last phase that the patient progressed to is the Hep B E antigen negative chronic hepatitis. A little bit on acute hepatitis infection. So this is when the patient has detectable Hep B surface antigen in the blood after an incubation period of 4 to 10 weeks. The appearance of antibody against Hep B core antigen, so this is the IgM, can be seen in the early phase. In this phase of acute hepatitis, patient can have very high Hep B V DNA, up to 2 million international units. They have a detectable circulating Hep B E antigen, and in this phase, patient can readily transmit the infection. Now, 30 to 50% of patients can present with icterus jaundice after an incubation period of 6 weeks to 6 months. In the immune tolerance phase, this phase occurs, so this is the first phase of chronic hepatitis. So this phase occurs in patients who develop hepatitis by acquiring it perinatally from Hep B surface antigen positive or E antigen positive mother. And this occurred, or the patients can develop this phase when they are in their early childhood. These patients have E antigen positive, DNA levels that are high, 200,000 international units, but they have normal liver function tests, so normal ALT. Liver biopsy will show very normal to minimal inflammation and no fibrosis. However, many of these patients will eventually develop E antigen positive chronic Hep B later in life, and most of patients with immune tolerance phase are of the genotype C. So again, the key to the immune tolerance phase is that they are E antigen positive, high DNA level, but normal ALT levels, and they can go through this phase for 10, 20, 30 years. The next phase is the E antigen positive chronic hepatitis. So patients these are the patients who got the infection perinatally, and they transition into this phase in their second or third decade of life. This phase is characterized by the presence of E antigen positivity, high HBV DNA level, greater than 20,000. Now they have high ALT, and histology begin to show active inflammation with or without fibrosis. These patients can have symptomatic flares mimicking acute hepatitis, and then the E antigen can disappear with the development of antibodies against the E antigen, and these patients then can go into remission. Sometimes these patients can have only transient decrease in their HBV DNA level without the clearance of the E antigen, and they can get hepatic decompensation. Now, if they do well, they can have spontaneous E antigen seroconversion, and this can occur in 10 to 20% of patients annually. The next phase is the inactive Hep B surface antigen carriers state. So after seroconversion, meaning after development of the E antibody, most patients remain negative for E antigen and positive for the antibody. Again, that's what seroconversion means. In these patients, they have stabilization of their liver function tests, so ALT levels are normal, HBV DNA decreased to a low level of less than 2,000 or undetectable levels. The histology or the liver biopsy in these patients shows very minimal to just mild inflammation with variable degree of fibrosis that could improve over time. The Hep B surface antigen clearance will occur eventually in many of these patients. A seroconversion can occur, so they can go back to developing the E antigen, and this can occur in 4 to 20% of patients. The final stage is the Hep B E antigen negative chronic hepatitis phase. So in these patients, they have progressed from the inactive Hep B carrier state, or they can progress from the E antigen positive phase into the E antigen negative phase. So in this phase is characterized by the absence of the Hep B E antigen, the presence of E antibody with detectable levels of Hep B DNA in the blood. Here, patients also have high ALT, but this can fluctuate, so it needs serial monitoring. In this phase, histological findings also shows inflammation of the liver with 50% moderate to severe inflammation or fibrosis, and 25 to up to 40% of patients have cirrhosis in this phase. Patients are generally older, have more advanced liver disease by histology, and they have a lower HBV DNA level. So it's a bit paradoxical in these patients in that they have the E antigen negative. The HBV DNA level may be low, but they actually have more advanced disease, and these patients may get treated at a lower HBV DNA level. And again, this phase, the E antigen negative chronic hepatitis phase, represents a more severe or progressive chronic liver disease because they have gone through the other phases of hepatitis and thus have developed some form or some degree of liver fibrosis or cirrhosis. This is a table on the diagnostic criteria for chronic hepatitis B, as well as the Hep B surface antigen carrier state, and then finally the recovered or resolved hepatitis B. So for the diagnosis of chronic Hep B, patient needs to have a Hep B surface antigen positive for more than 6 months, serum HBV DNA greater than 2,000, persistent or intermittent elevation of liver enzyme tests, and liver biopsy showing chronic hepatitis with moderate or severe inflammation. Inactive surface antigen carrier state, they can have the surface antigen positive, but their E antigen is negative. Serum HBV DNA is low. They may have normal, actually in the carrier state is characterized by normal ALT and AST levels, and liver biopsy show no significant hepatitis or inflammation. Recovered or resolved hepatitis B occurs in patients who have a known history of acute or chronic hepatitis B in the past, or they have the presence of the hepatitis B core antibody, but these patients have no surface antigen, no detectable serum HBV DNA, and they have normal ALT levels, so they have recovered from their hepatitis episode. Management of chronic hepatitis B needs serial HBV DNA monitoring to evaluate the need for treatment, as well as to evaluate the efficacy of therapy so far. Levels can fluctuate from undetectable to more than 2 million HBV copies, so serial levels need to be done. So in terms of management, it has to do with the treatment is different for E antigen positive or Hep B E antigen negative patients. And in E antigen positive, patients have high level of virus in the blood, normal ALT, and these patients can be monitored at 3 to 6 months intervals. And just a side note on the E antigen negative patients, these patients also have positive B antibody, normal ALT. The E antigen negative patients again have low level of virus in the blood, less than 2,000. And they can also be inactive Hep B surface antigen carriers, and these patients need to be monitored in terms of the ALT every 3 to 6 months. This is a schematic of management of Hep B E antigen positive carriers. So depending on the E antigen again, so this is going down the E antigen positive path. You look at the ALT levels. If it's essentially normal, then you just need to monitor the ALT every 3 to 6 months. Monitor the E antigen every twice a year to make sure they don't go into the E antigen negative, where treatment would be different. If the ALT is moderately high, 1 or 2 times the upper limits of normal, you check the ALT and the HBE antigen more frequently and consider liver biopsy if they have a persistently high level, or if the patient is older than 40 years old, and treat as indicated. If the ALT levels, on the other hand, toward the right side of the table, if the ALT levels are very high, more than 2 times the upper limits of normal, then ALT monitoring is even more frequent, and treat if persistently high. Liver biopsy is optional, and you treat immediately if patient develop jaundice or decompensated liver disease. This is the table or the flow chart for management of chronic Hep B in patients who are Hep B E antigen negative. Again, ALT monitoring is important. So to the right of the flowchart, when ALT levels are essentially normal and HBV DNA level is low at less than 2,000, again, in these patients, you just need to monitor the ALT every 3 months, and then every 6 to 12 months, if they continue to be normal, you keep checking until the ALT level is high, and then you go to the next well, if their ALT is 1 or 2 times the upper limit of normal and their HBV DNA start to climb from 2,000 to 20,000, then checking the ALT and the DNA level should be done more frequently, and consider biopsy now if this is persistently high, and treat as needed. And the last option is that if you see the ALT is already very high, at least 2 times the upper limit of normal, and their HBV DNA is already high at more than 20,000, then treat. And again, here it's mentioned that liver biopsy is also optional. But you essentially treat if the ALT or the HBV DNA are persistently high in these HBE antigen negative patients. Now going to antiviral drugs. There are currently 7 agents approved for the treatment of hepatitis B, treatment of chronic hepatitis B in the adults in the U.S. And they fall under 2 categories: the interferons, and secondly the nucleoside or nucleotide analogs. So of the 7 agents, the first is the standard interferon alpha, and then pegylated interferon alpha 2A, that's Pegasus. Then we have lamivudine, adefovir, entecavir, tobevudine, and tenofovir. The other drugs on the right side also have activity against hepatitis B, but they are not in the approved agent for chronic Hep B treatment. But these are emtricitabine. Clevidine has been studied in the past but was discontinued in clinical trials due to significant myopathy side effects. And then a combination of the seven have also been studied and used for treatment, but there's no established guidelines as to which combination is the most optimal. So the interferons, the advantage rather is that there is a defined course for treatment with interferon, so it's 16 to 48 weeks, and it is not associated with the development of resistance. The disadvantage is that it has to be given sub-Q. Patient develop flu-like symptoms as well as severe depression, and they can have hematologic abnormalities. The nucleoside analogs have advantage is that it's given orally. It can give more HBV DNA suppression, and it can be used in patients who are not responding to interferon therapy. The disadvantage of nucleoside analogs is that it can increase HBV DNA replication if the drugs are stopped prematurely. Patients can have reactivation of hepatitis, and the other side effects are renal toxicities as well as myopathy. This is a table. It's small to see, but this is the reference is at the bottom. Is where just list the approved antiviral therapies that I just went over. The the 7 agents, and the treatment is classified for E antigen positive patients and then for E antigen negative patients. So this is the E antigen negative, and the drugs are across the top. And basically, the efficacy of which drug or which medication is placed at the preferred therapy as opposed to alternative therapy is based on variables such as what percentage or its effectiveness in reducing HBV DNA level in the blood, its efficacy in improving liver biopsy, or normalization of ALT, and as well as durability of reducing viral levels in the blood. This is a similar table from the AASLD practice guidelines against response in treatment naive patients with Hep B antigen positive. And again, the medication across the top, and the higher the percentage, the higher is the efficacy for that particular medication in terms of suppressing HBV DNA, normalization of ALT, or liver biopsy improvement. So for example, under entecavir, you see the percentage at 67 for the loss of serum HBV DNA. Tenofovir 76, so that's higher than the others. And then also, for example, 72% improvement in liver biopsy under entecavir, and 74% for tenofovir. So that's why those two medications, as you will see, will be in the preferred medication for treatment of chronic hepatitis B. And this is the second table for Hep B E antigen negative chronic hepatitis B patients. And again, the same idea. So who should be treated? Therapy is indicated in patients who are having rapid deterioration of liver function tests or having decompensated cirrhosis. Patients with HBV who receive immunosuppressive or chemotherapy should also be treated, because these patients have high risk for developing exacerbation of severe hepatitis. Patients who should be treated also are infants of Hep B surface antigen mothers, and these patients, again, these infants should receive HBIG and Hep B vaccine within 12 hours of birth. Another note: patients who receive immunosuppressive or chemotherapy should be treated, and these include patients who have chronic hepatitis B or patients who are inactive carriers. Now, therapy may be indicated, so not necessarily treated. Therapy may be indicated in patients who have high viral level, so high HBV DNA. They have signs of liver inflammation as reflected by high ALT or by inflammation on liver biopsy. Patients in the immune active phases, these are patients with high HBV DNA with or without the E antigen, with evidence of active liver inflammation by high ALT or by liver biopsy. So these patients may be treated. Patients in the immune active phase who have complications from chronic Hep B, they start to have complications from chronic hepatitis B essentially after age 40. So those patients may be considered for treatment. Younger patients with Hep B E antigen positive, they can wait due to spontaneous HBe antigen conversion. Now, if seroconversion does not occur by late 30s or early 40s in the patients who are in the immune active phase, and if they have active inflammation by biopsy, then those patients may be treated. Patients who are in the reactivation phase, meaning they have high HBV DNA levels or liver inflammation, may be indicated, and there are prognostic factors that are also considered in treatment. So if patients who are male have genotype C, who have family history of HCC, patients who are having ongoing alcohol use, or patients who are co-infected with HIV, HCV, or hepatitis B may be treated rather than hold off. And lastly, patients who do not need to be treated immediately are those who are young, who are in the immune tolerant phase, who are the healthy inactive carriers, patients with latent HBV infection, meaning they have no signs of liver inflammation, but may have very low level of circulating HBV DNA, or a patient with no evidence of liver inflammation may not be treated. And then patients who are non-adherents or have a history of not taking medication appropriately do not need to be treated. And then also patients who have severe comorbidities where treatment with hepatitis B medication may make their condition worse. So these patients do not need to be treated immediately. And again, immune tolerant, I'm just outlining as to what that means. Inactive carriers, what does that mean? And latent HBV infection. Our patients, again, with detection of HBV DNA but no surface antigen positivity. And this is a table that if you decide to treat a patient for chronic hepatitis B, you can go to a table like this in the practice guidelines where it's based on Hep B E antigen positivity or negative, the HBV DNA level, and ALT level. And based on that, you either observe, consider biopsy, or treat if they're jaundice or have liver decompensation. I'm looking, for example, at the second option here where the patient is E antigen positive, HBV DNA is greater than 20,000, and ALT is greater than 2 times the upper limit of normal. So in those patients, if you go through the treatment strategy, they can be treated with interferons, lamivudine, odephivir, and entecavir, tenofovir, etc. And then it outlines for you as to which one is preferred or not preferred based on drug resistance or based on antiviral activity. And then that's also outlines the endpoint of treatment. So the endpoint of treatment for that group of patients would be seroconversion from E antigen positive to the E antibody. And the guideline also outlines the duration of therapy. So for example, if interferon is used, It's either 16 to 48 weeks, depending on if it's the standard interferon or the pegylated interferon alpha. And then for the other oral medications, the treatment duration is a minimum of 1 year with continuation of treatment for at least 6 months after the conversion from the E antigen to the E antibody. So again, that's the table for reference. The goals of antiviral therapy in patients with chronic hepatitis B is to suppress HBV replication and to prevent to achieve remission of the liver disease, and then ultimately to prevent cirrhosis and hepatic failure, as well as hepatocellular carcinoma. Monitoring of patients with chronic Hep B on treatment. So in patients with E antigen positive, in patients who are E antigen positive, it's outlined, every 12 weeks the DNA level needs to be checked, as well as ALT, and every 24 weeks the E antigen or the antibody levels need to be monitored. Patients with complete response, meaning those who have undetectable HBV DNA and those who have seroconversions to the antibody, may stop therapy after 6 to 12 months of consolidation after they have seroconversion. The durable response rate is up to 80% in E antigen positive patients, but there are overall limited data. Patients are monitored for relapse with testing for HBV DNA level as well as E antigen status. Now, for patients who already have cirrhosis, treatment for hepatitis B continues rather than stopping after 1 year to 1.5 years after seroconversion. And that is the end.